Hi and welcome. I am Dr. Robert Glatter, Assistant Professor of Emergency Medicine at Northwell Health and attending physician at Lenox Hill Hospital in New York City. When Hurricane Maria struck Puerto Rico on September the 20th, it upended the island's infrastructure. Almost a month after the storm, Kaiser Health News reported that many of the island's 3.4 million residents were still unable to get nutritious food to eat, let alone medication or treatment for chronic conditions such as heart disease or diabetes. To help with the situation on October the 26th, New York Presbyterian Weill Cornell Medical Center began to offer free telemedicine peer-to-peer consults between New York physicians and a New York disaster response team stationed in Puerto Rico. Physicians used live conferencing to treat a total of 4 patients through an effort coordinated by the Greater New York Hospital Association and Healthcare Association of New York State under the auspices of the U.S. Department of Health and Human Services, the State of New York, and the Puerto Rico Department of Health. Dr. Sherry Platt, Chief of Pediatric Emergency Medicine, and Nancy Pagan, Emergency Medicine Physician Assistant, are here to talk to us about the program today. I want to welcome you both, and thanks again for taking the time to come here. Dr. Platt, I'll start with you. Can you tell me about the mechanics of the program and exactly how this was set up and what the need exactly was for having such a program?
Sure, absolutely. After the disaster, it became obvious that New York Presbyterian were likely to send a team. We had sent teams after Katrina and after and to Haiti, and we realized that there was going to be a need in Puerto Rico. Under the leadership of Jeff Boxer, NYP, EMS, emergency medicine physicians at Columbia and Cornell, and physician assistants and emergency medicine nurses gathered together and determined that they were going to go. However, unfortunately, there was no way that every single service could possibly be represented. Right. So after the first 2 weeks, we recognized that there was a need for subspecialty expertise on the ground at Puerto Rico, and also particularly for pediatric support for our NYP colleagues. So Dr. Ruhul Sharma, who's the chief of the emergency department at Weill Cornell, New York Presbyterian Hospital, proposed using telemedicine as a resource for the NYP providers on the ground in Puerto Rico, and that would essentially bring all of the resources of New York Presbyterian Hospital to our providers who are in Puerto Rico, and to help allow us to provide that kind of broad care for the patients who are in Puerto Rico.
So was telemedicine an initial part of the plan, or was that something that developed secondarily after the team was already on the ground?
I don't know that it was initially part of the relief process, but it became, I think it's always, we have a very robust telemedicine program at NYP. We've already cared for more than 10,000 patients, either in the ER or from home. And so I think it's always on the forefront of our minds of utilizing it as a resource. So I think it probably happened simultaneously, but of course the priority was to send a direct mission team.
And what kinds of patients and how many patients were treated using telemedicine?
So we ultimately only cared for about 4, I'm sorry, can we redo that?
You can do it. We started. Yeah.
Okay.
So if you can ask the question.
I'll ask it again.
Yep.
Yeah, sure.
No
problem. Sorry. Say one.
Anytime.
So what kinds of patients were cared for, and how many patients did you care for specifically?
We ultimately only cared for 4 patients, but this was essentially a proof of concept mission where we were able to show the utility of telemedicine in this scenario. There were not delays, but it took time to develop infrastructure. We had to get approvals from many regulatory processes, including FEMA and New York State, and so even just the process of the approval took time. So by the time that we ultimately activated the telemedicine program, we then sent our second team, which Nancy was part of, and she can speak to that, with all of the technology that was needed to set up the telemedicine. That included laptops and cell phones and all of the technical equipment. And that was supported by our innovation team at NYP to allow us to develop, to make the connection and to provide the telemedicine resources. So we then did that for the second 2 weeks that Nancy's team was there for, and then it allowed us to do the peer-to-peer.
So it's almost like having a virtual emergency room at your fingertips if you wanted to call a consultant.
Exactly. We were essentially provided subspecialty consultation. One of the things that was particularly remarkable is once we finally got the green light to go, we then, Dr. Sharma and myself, reached out to our colleagues at NYP in all of the subspecialties, and we had an incredible response of basically everybody saying yes, they'll be available. All the cardiology and dermatology, pulmonary medicine, endocrinology, infectious disease, everybody basically said, of course, will be available.
Right.
And so we set up this as a resource. And maybe Nancy could speak to it. But
yeah, actually, that's what I'm.
Yeah.
So Nancy, and how did this work on the ground when you were there? Did you interact with the doctors and other consultants by telemedicine to sort of to carry out their orders or what they wanted to do, or you would transmit what the status of the patient was?
I did. I wanted to mention that there was a satellite once I arrived, October 24th, that helped us have access to this telecommunication.
Okay.
Team 1, it is my understanding, they were unable to use telemedicine because they didn't have this availability to them. And then that's when Rahul Sharma sent us down with laptops and mobile heartbeat phones, which are iPhones, that give us access. Once on the grounds, we did have an internal medicine physician, an orthopedic physician, during the week that I was in Manatí, Puerto Rico, at the family medical shelter working, and at the acute and non-acute emergency medicine, you can say tents, where we would see patients. And it felt wonderful to know that if I needed, the first case, for instance, if I can speak of it,
Sure.
required the expertise of a pediatric endocrinologist. And our internal medicine physician is in adult medicine, practices adult medicine, and didn't feel comfortable managing this 2-year-old. Neither did I. I work in adult ER.
Okay.
And I thought it was a perfect case to try to get the physicians at New York Presbyterian to chime in and give us their consultation.
What was wrong with the patient exactly? Can you describe what?
Yes, so mom brings in a 2-year-old who appeared well, except his glucose was extremely elevated, given that the insulin that mom had was not appropriately refrigerated. For obvious reasons, there was no electrical power and the insulin went bad. He came in and we didn't know how to manage exactly his type 1 diabetes. And we wanted to do the right thing and get the appropriate medication process, prescription, so that we can care for him appropriately.
Okay.
And that's when Dr. Shari
And so that
took over and gave
facilitated,
us-
right, having that connection really helped to facilitate
Correct.
care. Yeah. How did the child do after you had that, now that with the telemedicine?
He did well. He came back 2 or 3 days later. I don't know if we mentioned it, but
Yeah.
he was doing well.
So we got a connection on Mobile Heartbeat, which is iPhone, text that said, from Nancy that said, I'm in Puerto Rico and I need a pediatric endocrinologist.
Right.
We have a 2-year-old with uncontrolled diabetes. I reached out to our chief of pediatric endocrinology, Dr. Zoltan Antal, who within about 30 minutes, Dr. Antal and myself were on telemedicine screen with Nancy, and what was amazing for me was that we were able to, obviously we were doing peer-to-peer consultation, but we were also able to physically see the child and speak with the mother directly, and it allowed us to really become part of the care team in Puerto Rico, and more even than for us, but for her to realize that she was talking to people, and very soon, I don't know how much you have familiarity with telemedicine, but you sort of you lose the concept that you're on a screen, and you very quickly kind of just feel like you're having a conversation, and it's a very intimate relationship where you're free of distraction, and you're able to have a communication and really feel like you're you're the provider. And so we had Dr. Antal actually spoke to the mom and Nancy and guided her. This mom was amazing. I want to say that she really understood her son's diabetes. She knew his calorie counts, his insulin doses, but unfortunately she didn't have access to appropriate refrigeration for the insulin, and then she also didn't have access to her own provider. She couldn't reach her own physicians because of the hurricane. So he was able to guide her, changing his insulin doses, modifying his diet, and then we made a plan for her to return in 2 days, and she was checking his glucoses all along. But we were also able to watch the little boy. He was playing with our paramedics, and it was just, I felt like it was a really successful encounter.
So that brings us to the point of telemedicine. Can we really establish connections with patients? And you're saying yes, and that's good to hear, because there's been some argument that it doesn't have that warmth, that connection that you can have different than the bedside. And so speaking to that, what you just did, I think you kind of reinforced that notion.
I think that there is a tremendous utility to telemedicine, and you know, I live and work in the emergency department, so obviously it's an important environment to care for patients, but there are many patients who don't want to come into the emergency department and don't necessarily need to. And so I really think that it allows us to have a very close relationship with our patients. I think that you can, you know, you're free of distractions, so it's, in some ways it's kind of, it's quiet, and you're having a one-on-one conversation. You're able to make eye contact. There's a lot of clinical medicine that you can do with telemedicine, so I would share your questions, but I'm actually a big believer right now. I think it's great. And in the setting for a disaster, it was priceless, because we obviously can't send all of our entire subspecialty team to a disaster site, but it allowed us to really provide, you know, the opportunity for every single subspecialist at NYP to provide care for our colleagues on the ground.
Right. Do you see any other uses for telehealth or telemedicine, even more locally, instead of just, you know, like going to Puerto Rico?
I think there are countless uses, and I mean, we are even currently now expanding the program at NYP. We already use it for patients who are arriving in the ER to expedite their care, and there's been some research to prove that it's actually improved the delivery of care and the time to see a patient and their length of stay, and patient satisfaction is very high with it. But also for geriatric patients who might not want to come in the middle of the night, for little babies who might not need to come in the middle of the night, it gives reassurance, but you can actually, by seeing the patient, not a mere phone call, because I wouldn't rely on a phone call, but I do rely on my clinical acumen from being able to see somebody. So we're reaching out to a lot of different venues in Manhattan right now, in New York, to provide telemedicine to patients.
Do you think that's something that patients at Weill Cornell and New York Presbyterian will have the benefit of having this type of, in other words, relationship with their providers in the future?
They already do. So a lot of those resources already exist. It's also, we have a second opinion program where patients who might just want a second opinion are able to do that through telemedicine. So there are probably countless other opportunities for telemedicine to provide care.
Right.
Any
other thoughts? I wanted to
yes,
get your thoughts on that.
I'm a firm believer in telemedicine. Since 2006, our emergency room has implemented this for non-urgent appropriate cases, of which a few hours of my shifts, not all, but for instance, yesterday and today, I'll work 8 or 10 hours in the waiting room, and anyone that's appropriate for a telemedicine visit, I offer it to them. They agree. They see the physician. If it's a suture removal, for instance, I will do the work. They discuss the case. The attending speaks to the patient, gives them instruction, prints out their exit care, and hopefully they're out of the ER within 20 minutes, and they're very happy, very pleased.
These patients never come into the emergency department. They're treated, in other words, when you say telehealth, we'll offer a what do you exactly mean by that?
What I mean is when they come into triage and see the nurse and say, I'm here for suture removal, I am the mid-level provider that is there. And when I hear the patient say this, I offer them
Okay.
the opportunity to see an attending physician via a telescreen.
Oh, I see.
And
Okay. So instead of coming into the
99% of the time,
right,
they
I
say
see.
yes.
But they don't enter the department physically.
They'll follow me into a room that's
Okay.
designated for this.
I see. But it avoids
It avoids wait time,
Okay.
and that's one of the reasons why patients love it. They will come in, and hopefully if there's no one else in the telemedicine room, if they wait maybe less than 30 minutes, maybe from
Right.
start to finish, for something like a suture removal.
Right. Well, the question is, could this be accomplished in the home setting without a patient physically coming to the department? You know, why not offer this? In other words, go out to the people or have small centers or.
It
or
already
So
is.
we have
Yeah.
started that. There's an app at NYP
Okay.
on demand for offering telemedicine to the community, and patients just need to download the app and they can
Oh, okay.
access an emergency medicine attending physician at Weill Cornell, 16 hours of the day, every single day, and 6 hours of the day in the evenings, a pediatric emergency medicine physician. And it's one of our own doctors who
Okay.
on another day might clinically be working in the ER. So we're not outsourcing the physician
Sure.
staffing. And so they are really being seen by Weill Cornell medicine physicians.
Right.
And they love it. I mean, being able to get good care, most of the time, honestly, it's peace of mind. 'Cause, I mean, some of the adult patients are pretty complicated, but
Right.
we have seen a handful of pediatric patients, and most of the time it's patients who don't want to come in and they just want a doctor to tell them, is it okay?
Right.
And then a handful, a very small handful, we have advised to come in because in fact they needed to come in, and I think of those even more so because those are patients who maybe they would have chosen not to come in and
Right.
had they not had
Right.
that service.
We're always reminded of someone who calls the emergency department asking, you know, is it safe to take this medicine? I don't feel
Right.
well. And here's a sort of a perfect answer, a solution to why not
But
bring
you're
medicine
actually
to them.
seeing somebody.
Right.
You're seeing their child. You can watch them
Right.
breathe. You can watch them walk.
Right.
You watch their mental status. You can check their hydration status.
Right.
There's actually a lot that you can do through the screen.
And the medical legal aspects, though, of this are interesting too, because, you know, once you commit to, you know, visualizing a patient, having that encounter, you know, you have to bring that patient into the department. Can you adequately and safely treat them in the home setting?
I
And
mean,
that's something
it's
to
all
really
been
think
vetted
about.
through legal, so it's 100%. We are medical legally responsible for those patients.
Correct. Okay. Well, I want to thank you both very much so for such a good conversation, and it's been a pleasure to hear about your efforts, and I think this is all very worthwhile. Thank you again.
Thank you so much.
Thank you for having us.
Thanks.